Ego. Bye-bye. And
I can see Professor Shivendra has joined. Good morning.
Good evening.
Good afternoon now.
And
Good morning from UK. How are you?
Good morning.
So we are about to start.
Yeah.
We are all good, thank you. We are about 5 minutes late. With permission, Nafisa, can we start now, please?
I am Dr. Ali Nafisa, oncoplastic breast surgeon. Like to welcome you all to our today's session on the topic of the newly diagnosed breast cancer. We have a foreign faculty from UK, Dr. Chin, FRCS consultant radiologist, Buckinghamshire Healthcare NHS Trust, UK. Her early undergraduate and postgraduate years were spent in Belfast, Northern Ireland, where she graduated from Queen's University of Belfast. She undertook training in surgery, obtaining MRCS from Edinburgh, rotating through various surgical specialists, including breast and reconstructive surgery. As part of her breast fellowship, she spent a short training stint in the Nightingale Centre, Manchester, which is one of the National Breast Screening Training Centre. Dr. Chin, obtaining her FRCS in 2013, she has held consultant radiologist, post specialist in breast imaging, both within the symptomatic and screening aspect, since she is highly proficient in interpretation of mammogram, breast localization, and biopsy technique, like ultrasono-stereotactic vacuum assisted and breast MRI. We have faculty, Dr. S.K. Farid Ahmed, oncoplastic breast surgeon, Wickham Hospital, Buckinghamshire Healthcare NHS Trust, UK. And we have national faculty, Professor Khadimul Islam Sir, advisor and chief consultant surgeon, Lab-8 Specialized Hospital. We have another national faculty, Professor Dr. Shivendra Majumdar, Professor Head of Department Radiology and Imaging, Shahid Sohrawardi Medical College and Hospital, Dhaka. And we have another radiologist as a national faculty, Dr. Humaira Islam Khan, Fellow of Radiology and Imaging from Tufts University, Boston, USA, and she is working as a consultant sonologist at Anwar Khan Modern Medical College, Diagnostic and Hospital. I would like to welcome and invite Dr. Chin to deliver her speech. Dr. Chin, please. Dr. Chin, can you unmute yourself and start?
Yes, can you hear me now?
Thank you.
Yeah, so thank you for the kind introduction. Just a little correction. It's FRCR for the Fellowship of the College of Radiologists rather than of the surgeons. Thank you for inviting me for this talk. And what I'm going to be talking today is really on the surface, really basic, aimed at specialist registrar level. So if this is too simple for some of you, I apologize. Okay, let's start. So I'm a consultant radiologist in the High Wycombe Breast Unit now. I've been there for about 1.5 years, but I've been a consultant breast radiologist for 7 years now, since graduating from Belfast in Northern Ireland. So let's start. Just a little bit about my unit to start with. If you like it, my unit is kind of split into two different wings, one being the symptomatic side and the other one being at the screening sector. They're both specialized in breast screening service. The symptomatic wing is patients that are directly referred from GP for specialist opinion, patient coming in with breast symptoms such as lumps, skin, nipple changes. The GP will see them, and if they think the patient needs further workup, they will send it to us. We also get referrals from hospital directly, patients directly coming from A&E with painful abscesses, or other specialist clinicians who, as part of their investigation for the patient, found that patient has incidental breast lesion or breast symptoms, and then they refer them to us for further specialist workup. And this symptomatic side, we get about 120 patients per week referral. That was before COVID. Obviously now with COVID, it's a little bit less, but it's now picking up very quickly. In that subset of our service, we treat about 400 cancers in a year. The other subset, which is more for the imaging department, is the screening bit. This is where the National Health Service Breast Screening Program is taken. We do a 3-yearly screening mammogram for women between the age of 47 to 73. And these patients are largely asymptomatics. They come to our unit or our peripheral site unit. We have several units that does the mammogram. We do the mammogram, the patient go away, then we read the mammogram. If there's any abnormality, we bring them back for assessment. And if there is any cancers or any disease that needs treated, we would then refer on to the surgical side or the symptomatic side, if you like it to be seen that way. And we screen about 30,000 patients a year in my unit. And of that, we pick up about 200 cancers in a year in this site. So let's go straight into the breast imaging assessment, the triple assessment as we call it. What is it? So it's first and foremost, most importantly, is the clinical examination. In this unit, these are undertaken by the surgeon themselves, assess the patient to see if the findings are abnormal. And obviously they will then give the grading to this clinical examination, P1 being normal and P5 being suspicious. The patient will also get a form of imaging. This is the second part of the assessment, where the patient gets a mammogram or an ultrasound, depending on their age group, which I'll talk later on. We also do MRI of the breast very frequently, and these are more for treatment, part of their neoadjuvant chemotherapy workup, or MRI to help us supplement what the mammogram or the ultrasound cannot do. If there's difficulty in measuring the size in the mammogram or the ultrasound, then we use the MRI to help us troubleshoot. And also, if the patient has a lobular cancer, which we know tends to be larger or bilateral, because we use the MRI to help us to aid the treatment for the surgeon. Other type of imaging, this is not part of the triple assessment. We have CT, bone scan, PET staging, and these are mainly for staging and follow-up, oncological follow-up treatment. And the third part of the triple assessment is, of course, one of the most important bit for the breast imaging assessment is the biopsy, taking tissue samples to find out what type of tumor that we're dealing with. So this is a little snapshot of my little corridor, very, very busy in a normal daytime. Just gonna see if I can bring up a cursor here. Screen arrow options, okay. Laser pointer, okay. So you can see my laser pointer. So the mammogram, we have 2 mammogram units in this corridor here. The patient gets seen by the clinician, which is just across the way. Patient gets seen by the clinician, get a clinical examination, a clinical history, comes to get a mammogram, wait in the waiting area, and then comes to the ultrasound room to be looked at. So, and this is where I will normally sit with my mammogram, with my viewing machine to look at the mammogram before calling the patient in for their ultrasound. So let's talk a little bit about mammograms. What do we do here? We've been using 2D digital mammography in this unit for the past 10 years now. What are the indications for mammograms? Any ladies above the age of 40 comes to the clinic, gets a mammogram. It may well be sometimes the asymptomatic breast pain, but we will do a mammogram. And this is for screening purposes because we all know that small lesions are hard to feel. And we do pick up significant numbers of asymptomatic breast cancer from this patient attending this clinic. So we use the mammogram as a screening tool. And obviously, if the patient is below the age of 40, say in the age of 30, coming in with a lump, and after doing the ultrasound, if it is suspicious looking, we will then ask the patient to get a mammogram as well. There is no age limit to how young the patient can get a mammogram. In fact, the younger they are, if they come in with a suspicious clinical or ultrasound findings, it's more important that we do the mammogram because more often than not, we do see a more extensive disease in one breast or in the other breast even. Ideally, I would like to have patients above the age of 35 and above getting a mammogram, but in my unit, it is being agreed that 40 years and above is the cutoff for getting a mammogram. We do a two-view mammogram, a medial oblique, and also a craniocaudal view, an Eklund view if the patient has implant, and I will explain to you what the Eklund view means. It means that you push the implant in and you see more of the breast tissue at the front. We also use 3D breast tomosynthesis. We use that as part of our further views. Some of my colleagues in the sitting listening to me now probably are used to having digital mammography. And sometimes if you see an abnormality, you might change the position of the patient a little bit to get a more lateral view, or even compress a spot compression view to kind of clarify the nature of the lesion. Magnification view if there is microcalcification. Over in this unit, because we now have breast tomosynthesis, we stop using all these spot views and the lateral view. We sometimes do to help us a little bit, but this breast tomosynthesis is basically a 3D view of the breast, where instead of a single X-ray shoot through the breast of a single image, what it does is the machine will swing from 180 to the other side and takes about 11 images of the breast, and the software would then bring it together to create a 3D breast image. So moving on, when we have the mammogram, the level of suspicion of any abnormality seen on the mammogram recorded using the BSBR imaging classification, very similar to the BI-RADS that the American use, M1 to M5, M for mammogram, 1 for normal, 2 for benign, 3 for indeterminate, probably benign, 4 suspicious, and 5 highly suspicious. And we use this classification across all the triple assessment area, P for clinical examination, M for mammogram, U for ultrasound, and even the biopsy, they would give this as B1 normal, B2 as benign, and B5 as highly suspicious. It's used across the board in management of a patient. So this is how one of my mammogram unit looks like. My radiographer will be capturing the images for me, and we mainly use hologic dimension as our units. We do have a Siemens unit, but I do prefer the hologic dimensions. So moving on to the ultrasound. I mean, ultrasound is my favorite modality to image the breast. Really, before I became a breast radiologist, we have to do general breast work, and my other subspecialty was head and neck, because ultrasound is again very superior in assessment of the structures in the head and neck. But let's concentrate on the breast now. So for the ultrasound, we will be using a broad spectrum linear transducer of high frequency to look at any lesions in the breast. First line imaging modality for patients under the age of 40 because it's a non-radiation modality. How we do it is we look at the ultrasound, we will scan the breast in 2 planes, always in 2 planes, like you would in all imaging. You always see any abnormality or any body parts that you wish to look at in 2 planes. we look at the size, the shape, the position, the echogenicity, and the outline of any lesion that you see. And it's also one of the most frequent modality that I use to help me in obtaining a tissue biopsy, say for fine needle aspiration for lymph nodes or draining cysts, and doing a core biopsy of lesions. Obviously, you can also use other modality to do a biopsy, such as using X-ray to help us target a lesion. But I think that is a topic for another day, how we do stereotactic biopsy or localization of any lesion using X-ray. These are mainly for lesions that you cannot see on ultrasound, but can be seen on mammogram. And similar to the mammogram again, scoring system U1 to U5 for my report. And this is a snapshot of how the ultrasound department is. You can see that the patient will be here getting their ultrasound assessment. There will be trolleys all set up ready for biopsy if need be. And this is my imaging workstation to look at patient old history notes and to read their mammogram before I see the patient. Reading the mammogram before seeing the patient ultrasound is really, really important. Those of you sitting listening who does ultrasound would probably know that the mammogram would actually help us be more focused on the area that we're more interested in and find out, because not all lesions looks textbook cancer, because a lot of lesions look really benign or even not be entirely clearly seen if you are not aware that that area is what you actually need to look at. So how do I report a mammogram? So first of all, I would always look for any previous imaging. Very important to look at the a mammogram to see, compare previous, like for like, always very helpful thing to do. The next thing I will comment on is the breast density. A breast density BI-RADS. Again, system A for fatty mammogram and up to D for very dense. I don't tend to use the BI-RADS system, the American use, but I will say it as part of my report. The breast is fatty or the breast is very dense. The reason for saying this is because in a fatty breast, you'll be able to pick up any abnormality really easily, but whereas in a very dense breast, you could very easily not see any abnormality that's there. In this image here, I have a picture of the right medial lateral oblique of the right breast. And the second thing I would say is to comment on if there's any previous changes in the breast, like maybe patient has a breast reduction or previous surgery or an implant, for example. I would make a comment on if there's any changes in the breast. Then afterwards, I'll move on to describe any abnormality that I see. And the abnormality that I would tend to look at is looking at any mass, any distortion, skin changes, very important, very frequently and very easily forgotten about is looking at the skin itself, because especially in a dense breast, sometimes the cancer can look just like this, but the giveaway is the change in the skin, very thickened skin, and you know there's an abnormality there. Obviously, nipple changes, again, very important to always have a second look at the nipple as well to see if there's any retraction in there. And microcalcifications, of course, is also something that we would tend to analyze. It's a very, very big topic. Don't think I'll be able to show you microcalcifications in such a in the Zoom meeting setting, because it's really very difficult to see and assess. Again, then afterwards, my next line of my report would be the mammogram scoring, M1 for normal mammogram and M5 for an abnormality there. And I would also put in a statement of recommendation what the patient needs as a subsequent of this finding. And I would also tend to say, yeah, the appearances are in keeping with malignancy, or yes, the appearances are in keeping with a cyst. So I always believe that we, even though we might be wrong, but it's always good to give our opinion, because as a radiologist, we are radiologists and we should always give the clinician what we think clinically. So how I report my ultrasound. So if the patient comes in after having their mammogram, reported their mammogram, the patient comes in for the ultrasound. So first of all, do a 2-plane ultrasound target. First of all, I'll tend to ask the patient where the symptom is, because I want to go in and zoom in on where the patient is worried about. There's no point doing the whole breast without knowing what exactly that you want to look at. So first of all, I locate the area of abnormality that the patient is pointing out, the location of the lesion, name it, upper outer, lower inner, 6 o'clock, in o'clock position is also fine. The size of the lesion, what size it is, the outline of it, whether it's well-defined, irregular, lobulated even, or cannot delineate, meaning it's very infiltrative. You cannot see an outline at all. And those are the things that you need to describe. I always describe the lesion before coming to a conclusion. Very easy sometimes is to say, oh, that's a cancer, but it's always a good practice to say, where is it? What's the size? What's the outline? And then coming to a conclusion. And echogenicity, you have to describe as well. And other factors that you just in this way, the diagnosis, this is a papillary lesion. You can see that the lesion is very close to the underlying nipple, and you can see that it's within a duct with a fluid clogging behind it, proximal to the lesion. So just by describing it, even before you even tell the person you want to tell it to, the person would have known, oh yeah, that's a papillary lesion. So that's why I always go for describe the lesion first. And afterwards, if I do find something abnormal in the breast, then I will assess the axilla as well to look at the axillary lymph node and take it from there. That will be in another slide on how we look at the axillary lymph node. And again, the last line of my report will be the U scoring, U1 normal, U5 malignant. The recommendations will be what I think and what I'll do next. So coming into the axilla, if an abnormal lesion is seen in the axilla, in the breast, sorry, or in the mammogram, but not in the breast, I would do an axillary lymph node assessment where we at the cortical thickness threshold varies within centers. It's between 2.3 to 3 millimeters, center depending. In High Wycombe, we use a unit threshold of 2.5 millimeter. So I just like to describe how you would measure cortical thickness of the axillary lymph node. I do see a lot of radiologists, even in the UK itself, measuring the lymph node in a different manner. I know if there are any general radiologists out there with it amongst you all, you would tend to measure the lymph node. Okay, you can see a little lymph node in here. Trust me, it's there. You can see that little cortical, very thin cortex in there, and that's where we need to measure, which is the cortical thickness. You can see the lymph node is here. You do not measure the lymph node from this to this or that to that, because you would definitely get more than 1 centimeter or even 3 millimeter, and that would be classified as abnormal. In general imaging, any lymph node greater than 1 centimeter is something that we would tend call it as normal, abnormal, but we measure the whole lymph node in the general imaging setting. But in the breast, in the axilla, you measure the cortical thickness. So very important, this one here. So 2.5 millimeter is my cutoff. Morphology takes precedence as well. It's very important. Sometimes the lymph node can look less than a 2.5 millimeter, but if it is round and very dark, that's an abnormal lymph node in a setting of an abnormal findings in the breast. And also I'm sure the Bangladesh clinician or the sonographers will be able to tell me that, look, most of your patients have cortical thickness of greater than 2.5 millimeter. And it's very common because I work in the Western country. Most of the whites, the Caucasian, their lymph nodes are pretty much normal with a thin cortex. But for Asians or the African subset, I do find that the lymph nodes have quite a big cortical thickening. This is when you really need to take the lymph node morphology in the whole context on its own. If it is very nicely thickened evenly with a longer than rounder lymph node, then that lymph node is probably normal. I can talk a lot about axillary lymph nodes, so I think I have to move on now. And increasingly, we are are now required to score our lymph node as well, according to the A1 to A5 scoring. Again, A1 benign, A5 being definitely abnormal lymph node. We used to do FNA cytology for the lymph node, but not for the breast lesion. But now we are all changing to core biopsy for suspicious lymph nodes. I like core biopsy more than cytology because you all probably know when we do the cytology, most of the time, sometimes the samples are inadequate or the patients need to come back again, or the sample didn't dry properly, and the pathologist says, look, you have to repeat it. So core biopsy definitely get the area that you want to get at the first go without needing the patient to come back again for another biopsy. And so this is how I would do a biopsy setup. This is a setup for my ultrasound setting, but if you do a stereotaxis, which is an X-ray guided biopsy or a vacuum assisted biopsy, the setup is very similar. There are multiple needle sizes that we use, 7 gauge, 9 to 18 gauge. 18 gauge is the smallest that I would use for any biopsy. I very rarely use that. I like to provide a good sample for my pathologist. And the size that I would use is 14 gauge in most setting under ultrasound. Obviously, if it's vacuum assisted or stereotaxis, I would tend to go for a 9 gauge. It's a much bigger sample that you get. So sterile needle, local anesthetic, 1 or 2% of lidocaine you would use. Infiltrate 2.5 to 5 mil of local anesthetic into the skin and onto the lesion. Very important. The skin is the most painful bit. You could use afterwards a needle to make a little cut in the skin before introducing your needle, or you could straight away use the needle, go in and have and do the biopsy, because the needle tip is really, really sharp. Clean the skin. This is just a probe cover to make sure that I have a clean setting when I do the biopsy. And this is the sample pot. The sample goes into the basket before putting into the pot. This is just a little video on how you would see on an ultrasound. If I could make this video run, actually. Unfortunately, I'm not able to run this video, but yeah, so not able to run, but I've got a backup here. So this is how the biopsy needle looks like. So under the ultrasound guidance, you would see the lesion underneath the ultrasound, using the ultrasound probe, and you would then come in after doing the cleaning of the skin and local anesthetic. You would then come into the lesion and then close to the lesion, not at it. You would then go in and do a click, and the needle will capture a sample and comes out to capture the sample, and then you would then withdraw it. The sample would be sitting on top of this hub here, and you just strip it off to get the sample. And it does make a really loud noise like that, and most of my patients tend to jump before they when they hear that. So before I do the biopsy, I always let them hear it so that they know that this big noise is coming. And this is how the sample size would look like. I normally take 1 is enough, but I normally take 2. Sometimes I do take more depending on how confident I was when I got the area in the first place, or if I want to get more area for the pathologist to look at. And this is about 2 millimeter thickness with about 1.5 centimeter of length. And this is a very good core that I got. And obviously, even looking at the lesion, you could see that the cores are very hard, very turgid looking. This is a cancer that we've done a biopsy on just last week. So let's go on to the interesting bit. Just look at some cases before we finish the talk. This is an example of an ultrasound of a very benign entity. It's a simple cyst. How do we describe it? Very longer than it is wider, very well defined, very dark, echo poor, or very hypoechoic if you like it. And the darkness of this lesion or this cyst is very similar to my black of this computer screen. It's in there. So it's really great. That means it's a, it's a little cyst that we're dealing with here. Very easy to sort out the problem. This is a very flat cyst. I don't think the patient felt this, but you could easily use a needle, go in and drain the cyst for the patient. So this is case number 2, a little bit more tricky. But you can see that this patient has multiple lumps in both the breasts. This is the right breast and this is the left breast. A multiple lesion, very well defined, multilobulated. You would give this as a grading of U3, indeterminate, probably benign. So we took a biopsy of this lesion and it turned out to be a fibroadenoma, as you say, as you would like it. I don't have a single nice picture of a single fibroadenoma. So usually you can give a fibroadenoma a U2 because it does look benign, but we do tend to biopsy these fibroadenomas. And in my unit, any ladies above the age of 25 or any lesion bigger than 2.5 centimeter will get a core biopsy to confirm the nature of this lesion. Obviously, in Bangladesh, the practice might be different. In Europe, the practice are also different. If they think it's a fibroadenoma, they follow up this lesion to check that they don't change over time. But here in the UK, we tend to biopsy them, and if it's normal, we discharge them as fibroadenoma. So this is case number 3. A little bit more interesting now, a lady presenting with a lump in the right breast. You can see that there is a, you could say, oh, look, it looks relatively well defined, but if you look at it closely, it's just a little bit irregular. The margins are not very well defined, and you can see it a little bit more on the MLO view. It's a little bit more irregular on the MLO, on the CC view, sorry, but that's because you've got composite of all this breast tissue overlapping on top of this lesion, making it look more irregular, more ill-defined than it is. So you can see how a 2 view, the same lesion looks really different in 2 views, and hence this logic radiology that you always look at everything in 2 planes. So on the ultrasound, you could very clearly, easily say that, look, this lesion is hypoechoic in the upper outer quadrant breast, measuring X millimeter, very ill-defined margin, and this is appearances are in keeping with malignancy. So just looking at the lymph node for this patient, remember we were talking about the cortical thickness. So this is where the cortical thickness has been measured. Always the tendency to measure from here to there, but no, the measurement is from here to here. Try and angle the ultrasound to look at the lymph node at its most thickened point and measure it that way. So this is proven to be a metastatic lymph node as well. Moving on to case 4. This again is a tiny little abnormality that you see in the CC view. And on the ultrasound, you could look at it and say, oh, look, it doesn't look like the cancer that I've just shown you earlier, very dark, very irregular, which you would say, yeah, that's a cancer. But this, you think, look, that's where is the, very dark center of it, where is the shadowing, where is the irregular outline. But if you can look at it clearly, you can't really draw a pencil sharply around it. There's just a little bit haziness around the, the periphery of that lesion, and also the echogenicity of the lesion. I'm not very happy with, because you tend to get very grade 3 cancers tends to have the echogenicity very similar to the surrounding breast, really. And we did a core biopsy. This again was proven to be a ductal carcinoma. In this slide, I would just like to point to you, this is after my biopsy. What I've done is I put a little clip into the lesion. This lesion measures less than 1 centimeter. I think it's about 0.8 of a millimeter, close to that. You would ask, how small do you have to get before you can do a core biopsy? Ideally, any lesion above 0.5 millimeter, you should be able to get it under the ultrasound guided biopsy using this device. So I've put a little clip in there just to mark the area. Sometimes if the lesions are really tiny, when you do the biopsy, the lesion kind of becomes macerated and you can't see it afterwards. So you put in a little clip to mark the area that you've done the biopsy. on. Let's see if I've got a picture of it. Yes, I do have one. And there you see a little marker clip marking the site of where the cancer is, proving that that area was the area that you were interested in, and that was where the abnormality is. So the marker clip serves as a multi-purpose, really, to mark the place or to kind of help you. Sometimes you don't see anything on the mammogram, but you see something on the ultrasound. You put a little clip in, and then you take the mammogram afterwards, and you can see, oh yeah, so that's where the area was. It may well not be this, it could well be this. So, but the marker clip tells me, yeah, the area you're interested in is this. But you know, the marker clip is not for the radiologist, it's also for the surgeons as well. When the surgeons wants to go in to take out the lesion, the marker clip is there. I'll show it in a different slide after this. This is another cancer that we're dealing with here. This is in the right breast, inner quadrant, lower inner quadrant of the right breast. Patient has other findings in the breast, this multilobulated densities, which is cysts in the background there, but this is a very dense looking lesion, very spiculated, ill-defined. And on the ultrasound, you could see the very abnormal looking hypoechoic irregular mass in the breast, 20 millimeter. And this again is another lymph node. Now this lymph node looks slightly different from the initial one that I've shown you. Again, look at how we measure the cortical thickness. It's 5 millimeter. In this setting, we know that that's a cancer, so therefore we are suspicious of this lymph node. So we do a core biopsy of the lymph node as well. And also very important, when we report the axillary lymph node, we also want to comment on how many lymph nodes that we actually see in the axilla. And this is for the staging purposes. In my unit, if you have greater than 3 abnormal lymph nodes, then that automatically would then qualify you to have a CT staging for to look for any other metastatic disease. If there's only a single lymph node, that's not enough. Straight away go for a CT staging. This is the reason why we do that. I mean, traditionally we tend to do this when if we have a single abnormal lymph node, we'll then automatically do a CT staging. But we found that the pickup for metastatic disease in a single lymph node positive is very low, and we're doing a lot of normal CT staging unnecessarily. And that's why we're having a cutoff of lymph nodes greater than 3, then we'll do a CT staging. So this is another little lesion, a bit harder to see on the mammogram, but if I point it out, you'll be able to see that it's a ill-defined spiculated mass with distorting features in the upper inner quadrant of the right breast. And that's the corresponding lesion seen on the ultrasound. So this is a good case to demonstrate why mammogram is always helpful in looking at the breast as a whole. So this patient coming with a lump in the right breast, you could see that this is where the abnormality is. This is where the breast lesion is. That's looking very abnormal, very suspicious looking M4 event. But if you look closely, I don't know if you can see, there's a lot of microcalcification, pleomorphic calcification extending all the way from around the lesion into the nipple in a band-like manner. And similar here, you could see the area is really, really huge. These microcalcifications are high-grade DCIS. Obviously, if you palpate this abnormality, you will only be able to palpate this. You wouldn't know that there are more extensive disease in the breast actually. So what we've done is we have biopsied both area, one of the lesion and the other one further away of this microcalcification, to try and prove to the surgeon that the disease is indeed as big as we think, looking at the MRI, at the mammogram. And this is how the ultrasound looked like. It only picked the abnormal mass, again, ill-defined, irregular, with echogenic desmoplastic reaction around the lesion. So moving on very quickly to the next case. Now you have, this has all the findings that you would like to see on the abnormal mammogram. You see the abnormal mass, which is pulling in the breast as a whole and causing the nipple to retract with skin thickening. Then one of the missing element in here is the microcalcification. So if it's got microcalcification in there, then it's got all the, full work of the textbook that you want to describe abnormal lesion in the breast. And there you see in the breast, we've got a marker clip in there. You can see the very bright little clip in there. And this patient has a little marker clip put in there because over here, patients do get neoadjuvant chemotherapy for the treatment. And the clip serves as a marker because when the patient has had a very good response to treatment, the lesion would dissipate and the breast would look normal again. And that's when the surgeon would need to go in to take out the area where the cancer initially was. And this marker clip would serve as the marker where the radiologist goes in, put a wire in, and tell the surgeon, this is the area that you need to take out. And again, the ultrasound very nicely demonstrating the ill-defined nature of this lesion. And remember, I did say, look for associated findings. You could see that the lesion extends into the skin in this instance, and you would describe that in your meeting. This is just a little picture to kind of show you how we do the tomosynthesis image. I'm not able to show you the 3D image, but I'm able to show you the synthetic image, which is called the C-view in here. This is the conventional 2D mammogram that most of you are aware of, this spiculated mass in the upper breast. And if you see, do it on the 3D tomo, you look at it as a video, and it really sharpens the image. And this synthetic view is when this software creates a really nice crisp image of the lesion that you can see and measure or delineate more clearly for the surgeons, giving them a better measurement of the abnormality or any other associated findings that might be that you don't see in your conventional 2D. And this is in your craniocaudal view. You can see this is a conventional 2D, very hard to measure. Is it from here to here, or is it from here to here? But the C view is able to very nicely kind of give you a little bit more of an outline of the lesion and make it a better measurement for you that you can correlate with the ultrasound findings. And this is the ultrasound finding of the mass in question. Another case here. If you look at this mammogram, you might think it's quite a moderately dense breast, BI-RADS category C, if you like it as this, for this mammogram density, BI-RADS C density. You don't see any abnormality in there, but the patient did present with a little lump in there. And on hindsight, of course, you would say, oh, look, that's where it is. And when we did the ultrasound, of course, we see where the patient is pointing out to us. But when we were scanning through, there were also little areas, very vague, very, very uncertain. Is it normal? Is it abnormal? We're not sure. But it's there. One could dismiss it as, it's a fibroadenoma or some papillary lesion, or even, some little non-specific benign things that you happen to capture at that slice, but there are little very vague changes in the breast. So we did a biopsy of the core lesion, and it turned out to be a lobular cancer. So I have the MRI of this patient here showing you the lobular nature of this breast. And this is when in the beginning of the slide, I talk about how the MRI helps us to troubleshoot tricky cases. So if you look at that, the disease is indeed multifocal, multicentric, involving the whole of the right breast. You can see this is the left breast, which is completely normal, and the right breast with all the enhancing ill-defined lesions that you see in the right breast. This is another case of a patient presenting with a palpable lump, irregular U4, you would call this irregular U4, suspicious for malignancy. We did a core biopsy of that lesion, and again, this lesion is of a lobular nature. So because it's lobular, we do an MRI. So that's the lesion that of question that's been biopsied in the lateral aspect of the left breast. But if you look at it, the MRI is also telling us there's another lesion just behind it that we haven't quite seen on the ultrasound or the mammogram even. So we went back and did a core biopsy of this lesion, knowing what we see on the MRI. And that lesion in question that we've marked with a marker clip, this marker clip has got a round and O circle. We call this an O twist marker clip. And that turned out to be a second focus of cancer. The first focus that we did a biopsy is here. If you can see that little red white marker at the front there, and this is the lesion in there. Very hard to see on the mammogram without the clip fitting where the mammogram is. You'll be hard pressed to say where the lesion was on the mammogram. This is one of my last cases here, an architectural distortion. This is in our conventional spot view that we used to do before we have the tomosynthesis. You can see an architectural distortion with no real mass seen on the ultrasound, but it's still abnormal nonetheless. This was diagnosed using a mammographic X-ray guided biopsy, where we did a biopsy of this lesion. Turns out to be a malignancy. She then subsequently needed to have surgery on that. We put a marker clip after we've done the biopsy. Remember, distortions sometimes are really small, and sometimes when you do the biopsy using a big gauge needle, that area might be completely removed and looks very normal on the subsequent mammogram. So that's why you need to put a little marker clip to mark that place. So when the patient is ready for the surgery, we put a little wire through the area that we have put a marker clip on. The wire is very similar to the biopsy needle. The method is similar. You put some local anesthetic in, needle goes in, push the hook wire through that and remove the sleeve, and the wire will mark the place for the surgeon. And again, this is in the MLO view. You could see the needle very nicely just passing through the area of interest where the marker clip is, just sitting nicely beside it. Very important when you place the wire must always go through the lesion, not at the lesion, so that the surgeon can have an anchor to pull onto the lesion when they excise around it. Not just pointing, but actually skewering the lesion using the wire. And this is the sample specimen that the surgeon has removed. They would then take an X-ray of that specimen to check that they have removed the correct area. And you can see the wire and the marker clip sitting next to that. So very nicely done, this one. So that's all for my presentation, really. Just open the floor now to questions.
Thank you, Dr. Chin, for your nice presentation. And actually, breast cancer management, for the breast cancer management, intervention is mandatory. And I would like to invite all you in the question answer session after the comments from our faculty member. Know that about 60 participants here, and our honorable VC of Bangabandhu College, Bangabandhu University, Dr. Konokkanti Burua, sir, also joining with us. Sir, Assalamu alaikum. Hello. Sir, Assalamu alaikum. Can you hear me? Okay. And first of all, I'd like to invite Dr. S.K. Farid Ahmed, sir, oncoplastic breast surgeon, to say something, few comment. Hello.
Thank you. Thank you very much. Well, I'd like to first of all congratulate Dr. Chin for her excellent talk. And I know she's on annual leave, and despite her busy schedule and private time, she managed to join us and share her expertise. As a developing country, Bangladesh, we know there are a lot of things, there are a lot of scopes we need to develop, and to provide a modern management of breast cancer, just to establish it there in Bangladesh, we need to have a multidisciplinary approach where we can develop not only just the surgical perspective, but also a diagnostic modalities, because the radiologist colleagues are the part of the key component of the multidisciplinary team, and their expertise are equally important, as well as our pathologist. Is basically the whole team is quite important. Everyone needs to develop, and she has shared some very valid nitty-gritty things. The radiology perspective, what is important, we should look at on practical grounds, sharing all those cases, and very important, very eloquently. So I'm very impressed, and thank you very much once again. I wouldn't take much time, so I would say thank you once again, and I'll just give it back to Nafisa. If you ask my other faculty, fellow
Yeah.
respected colleagues to give some comments, please. Thank you.
Thank you, Dr. S.K. Farid Ahmed, sir. I would like to invite Professor Khadimul Islam, sir, to say a few comments on this speech. Professor, sir, please unmute yourself. Khadim, sir, please.
Yes, can you hear me?
Yeah.
Yes, I can, Dr. Islam.
Okay. First of all, I would congratulate Dr. Chin for your very excellent talk. It's basic as well as, I must say, some advanced information. And we surgeon, as a part of the multidisciplinary approach to breast treatment, breast management, breast problem management, definitely I must say that the radiologist, sonologist part in the triple assessment for initially to have the correct diagnosis is very, very important, very, very important. And now we cannot think of just proceeding on the basis of mere clinical suspicion and clinical diagnosis. We must have to have the appropriate imaging, and then based on the suspicion of imaging scale, then localization of the lesion, the targeted biopsies, and then having the tissue diagnosis and ultimate planning of the therapy. So in this multidisciplinary approach, the role of the radiologist, I think, needs no further explanation or giving much more importance than any other thing. So it is very vital and fundamental to have the appropriate imaging, and where we should go for mammography, where we should go for the MRI, where we should go for the ultrasonography. Basically, ultrasonography and mammography, these are complementary, as you have also shown in your case presentations, that in fact, both sonology and ultrasonography are complementing or supplementing each other. But the interventional point of view, that is the expertise of the sonologist and the radiologist. And nowadays, we, the surgeon, are very much privileged to have this sort of procedure, particularly the wire localization, putting the marker clips, and then picking up the suspicious lesion. And then it becomes very easy for us to go for more particularly when we are thinking about the breast conserving surgery.
Yes.
So thank you, Dr. Chin, for your nice presentation. And I think this will generate much more interest among the radiologists and sonologists working in Bangladesh. And we are not that much lagging behind. Our young sonologists, radiologists, they are also now coming up with this interventional technique, and we, the surgeons, are now privileged to utilize those facilities for the better management of our patient. Thank you, Dr. Chin, again.
Yeah, thank you, Dr. Islam. Thank you.
Thank you, Professor Khadimul Islam, sir, for nice talk. I would like to invite Professor Dr. Shibendu Mujumdar, sir, Professor and Head of Department Radiology and Imaging, Shohid Sohrawardi Medical College, Dhaka. Sir, please, a few comments on this.
Thank you. Thank you, Ms. Chin, for your nice and time-demanding presentation and wonderful cases. We are grateful to you to see the nice cases, and by your nice demonstration and collaboration with the different images of a same lesson. It is very important to realize and to correlate and for your fine diagnosis.
Yes.
I want to congratulate Mr. Farid, who is trying to develop the breast oncosurgery and radiology collaboration in Bangladesh. And thank you, our legend professor, Professor Khadimul Islam sir for his nice opinion and collaboration with the radiologist and surgeon. And lastly, I thank the moderator, Ali Nafiza. She is trying her best to arrange this type of webinar time to time and helping us to gather knowledge from the abroad. I am grateful to her also and Dr. Farid also.
Yeah.
In our country, we are also doing this. And as Sir Khadimul Islam sir, our radiologists are doing now the interventional radiology. We are putting and the marker setting. And nowadays, very frequently, high resolution ultrasonogram machine is available in our country. And I am also very in favor of ultrasonography in breast as it gives us the details, image, less cost effective and also non-ionizing. So I practice like you. First, if it is mammogram, then I do ultrasonogram, and in correlation and taking the proper history and report like by that or wide approved system.
Yes.
So again, thank you, Ms. Chen, for your nice presentation and helping us to gather knowledge about the diagnosis of breast cancer, also about the lymph nodes, where the measurement, how to measure it, and when to measure it.
Yes.
Thank you very much.
You're welcome, Mr. Majumdar. Very welcome. I'm always happy to help. If there's any issues in the future in terms of mammography, I read a lot of mammograms here. Most of them are double reported with other colleagues. I read up to 8,000 to 9,000 mammograms a year. So if you have any worries about any mammogram, please either send it over. I'm happy to look and give you what I think the mammogram means.
Yeah, we would be very beneficiary if we have no dedicated breast center still now.
Yes.
Just haphazardly, scatteredly, we do this. So a dedicated breast cancer imaging system is very necessary to gather a lot of patients like your center.
Yes.
We will be happy to see further the different cases if you show us. Thank you.
Thank you, Dr. Shubhendu sir, for your nice speech. And I'd like to invite Dr. Humayra Islam Khan, consultant sonologist, Anwar Khan Modern Diagnostic Center and Hospital. Please, ma'am, to this session. And you know that Dr. Humayra Islam trained under Chin and others, colleague of Chin at Wickham Hospital, and intervention regularly with the Farid Ahmed sir and me, and she helped lots of help for us and support us. So we think that in future our this expert will expand and disseminate at other side of the country. So Dr. Humayra ma'am, please a few comments on to this webinar. Madam, please unmute yourself. Thank you.
Hello, Chen and everyone in the panel. I'm very happy to participate in the webinar. I've been working as consultant sonologist in Anwar Khan Modern Hospital for last more than 22 years. And we have been doing lots of breast ultrasound and also biopsies like basically FNSEs and plus scores. And then this Farid and Ali Nafisa, their team came up to make a breast care unit. Then along with them, we started wires, hydromarks, and more core biopsies. But I wasn't really very sure of the angles and about how to go through it directly into the lesions, you know. we weren't very, I wasn't very confident. So, then by the help of Dr. Farid, I went to your hospital, High Wycombe, Buckinghamshire. Then I was there for about 2 weeks. And Chin, thank you for helping me out how to really, really find a parallel angle going directly into the lesions. Yes,
Yes.
it does need lots of practices and efforts, and the chunk of meat along with olives inside does really help people how to get into the main lesions. And we have done, after coming back, lots of wires, hydromarks, cores with much more ease than before. Of course, it needs still brushing up and getting the expertise into hands.
Yeah, well done, well done.
And I will see you in near future when things get normal. And you gave an excellent presentation.
Yes.
Thank you for helping us all again. Thank you, Professor Khadimul Islam, Nafisa, and Dr. Farid, and everyone else who is participating in the webinar. Thank you so much.
Thank you, Dr. Humayra Islam. We have today in our webinar lots of senior surgeons and sonologists are joining with us, like Kanti Borua, VC of Bangabandhu, BSMMU, Dr. Shagupta from Square Hospital, Dr. Nishat, Madam, actually, our legendary best surgeon in Bangladesh, and Dr. Anwar Hussain, sir, Professor of Surgical Oncology, Dr. Shetabur Rahman, Professor of Surgical Oncology, Mahmood sir is also with us. Dr. Tara, I would like to invite Dr. Shagupta ma'am to say something on our today's webinar. Hello, can you hear me? Shagupta ma'am.
Is she with us?
I would like to invite Dr. Anwar sir, AFM Anwar. Sir, can you hear me? Sir, hello?
Yes. Yes.
She's raised her hand.
I can hear you.
Yeah. Sir, can you say something about our today's session?
First of all, I would like to extend my gratitude and honor to Professor Khadimul Islam, as because he's my teacher and I have had the opportunity to have my initial surgical training at Dhaka Medical College Hospital under Professor Khadimul Islam. And
thank you.
And along with this, I extend my gratitude and thanks to the organizer for arranging such important issue regarding the management of breast cancer, where it is very much appropriate to have the sonology and mammographical examination. As a part of routine examination following cell breast examination and clinical examination, this is the important tool before doing any type of intervention, whether FNAC, or core biopsy or even excisional biopsy. Before that, we must have the radiology, imaging. This type of investigation should be completed before doing any other intervention. So the important issue is that by seeing all these different cases which Dr. Chen showed us, this is very much important, and I think it is a part of learning curve for all of us, not only the junior but also for senior. So thanks a lot to Dr. Chen for her beautiful presentation, and along with this, thanks to Dr. Farid and Dr. Nafisa. Thank you all.
Thank you, Anwar Hussain sir. I like to invite Professor Nishat Madam Can you unmute yourself and put few comments on this today's webinar, madam? Nishat, madam, can you hear me? Nishat, madam, can you unmute yourself and few comments about today's webinar?
Alin Afisa for organizing this fine session. I'm extremely enlightened in this session. Assalamu alaikum, Khadimul Islam sir.
Walaikum
He's my
salam.
teacher, and I always acknowledge him, and he's the guide of me. And thank you, Jane.
You're welcome.
In my practice, I always prefer fine ultrasound. Ultrasonography of breast is only the, except mammogram, ultrasound can guide a surgeon perfectly if the sonologist is kind enough to tell the every aspect of the tumor. As it is low cost,
Yes,
less time consuming,
correct.
and comfortable, not painful.
Yes.
So a good sonography may guide a surgeon a lot. Thank you, Jane, for your kind
Yeah, you're
presentation.
welcome.
Thank you.
Thank you, Nishat, madam. We will go
Welcome.
question and
Welcome.
answer session shortly, and our today's recorded lecture will be available on our YouTube channel. Now I would like to invite Dr. Shetapur Rahman sir, Professor of Surgical Oncology, and Shetab sir, to put your few comments about today's webinar. Shetab sir.
Hello.
Yeah. Assalamualaikum, sir.
Thank you, Dr. Chin, for a good presentation about regarding the mammogram and ultrasonogram, which is very helpful for us for the diagnosis, initial diagnosis of breast cancer and axillary evaluation. Without mammogram and ultrasonogram, early breast cancer detection is not quite impossible.
Correct.
Though in our country, most of the patients come to us with advanced disease, mostly either locally advanced or with distant metastasis.
Yes.
And it is very important for the digitalization of the breast lesion, small lesion with the mammogram, and also digitalization of the small lump with the needle injection is very important. And
yes.
The lecture is very helpful to us and for the junior surgeon and also the junior radiologist and the sonologist. In our country, the provision of digitalization of the breast lump and axillary lesion through the mammogram and ultrasound is not so much popular. And this is why this lecture is very important to us. And thank you to Dr. Farid Sahib for also arranging the session and also Dr. Alida Pisa for the arranging the session. Thank you to all.
Thank you, Dr. Shetabur Rahman sir. I would like to invite Dr. Ayub Ali to say something. Hello.
Nafisa, can you hear me?
Yeah, I can hear.
Thank you, Ali Nafisa, for inviting me to say something. Actually, I am, though this topic is not very related to me, still, I think, as plastic surgeon, because actually our aim is to cure the disease. In that case, when it's completely cured, then it comes to the plastic surgical point of view, the reconstruction. So I think of what Dr. Chin emphasizes, that it's one of the approaches to cure the disease, because if the diagnosis of the breast cancer is done earlier, then it's possible to cure the disease. And what we learned from Professor Khadimul Islam, from my training, I am proud to say that he was my trainer in 1998 and 1999 when I was his registrar. He tried to popularize that how to do a breast surgery in a proper way or in the right way, and that's why it can be cured the disease. And that's why I think the SK Farid, he is the actually right person to do, and the support by Professor Khadimul Islam, it's I think a good collaboration, and that's why I will congratulate Dr. Chin. But Chin has presented very nicely. And I think this webinar definitely helpful for not only the juniors, I think it also helpful for all the other seniors. And I will thank Dr. S.K. Farid and my trainer, Professor Kadul Islam. And I'm happy to talk here. And thank you all the other faculties here and all the others who are joining with this seminar. Thank you very much. Thank you all for giving me the opportunity to talk something. Thank you.
Thank you, Professor Ayub.
Thank you, sir.
Thank you, Professor Ayub Ali, sir. I would like to invite Dr. Shagupta to say something about our today's session. Ma'am, can you hear me? Hello?
Yes, can you hear me?
Yeah, we can hear you, ma'am.
Okay, I'm Dr. Shagupta, consultant radiology working at Square Hospital for last 16 years maybe. But the thing is we have got everything regarding imaging like mammography, tomosynthesis, ultrasound. We have MR mammography, everything related to breast scanning and for detection of cancers. So, but the problem is that we sometimes face little difficulties and we are not so much apt in doing like interventions like marker placement or guide wires. So it will be beneficial to us to and also for the junior radiologists to get some sort of training regarding that.
Yes.
And it will be very much helpful for the surgeons to properly locate the lesions, especially after chemotherapy, you know, because a lot of cases we can't get any lesions even by doing MR mammography after chemotherapy and treatment. So I think something can be done regarding collaboration with your institute and so train up a few radiologists in those sectors. Otherwise, we are using here the BIDATS classification system. And I had one question, like in case of sonomammo, we are doing a lot of sonomammos these days because one of the investigations is not enough.
Yes.
So how do you categorize or how do you do the conclusive, you know, the grading or reporting? Like you can just put two separate things like ultrasound U and M, or you can just put a combined thing over there for reporting purpose. That's my question to you, Chin.
Yes, I always read it as independently. I will look at the mammogram independently and grade it independently, and I'll do the ultrasound and grade it independently. I'm sure in your experience, you would have seen something that looks completely mammographically normal, but when you put the probe onto the patient, it looks like a U5 lesion. And then you go back to your mammogram because you already know where it is. You go back, you said, you know, that's maybe that little density was where the cancer was. So the always temptation is to then grade your mammogram as an M5 after you know what the ultrasound was an U5. I would encourage you to do that because you always want to give a very honest opinion without knowing what the ultrasound is. Yes, because it's very important because that means that the lesion is actually mammographically occult. If you say it's M5 after looking at the ultrasound, then the lesion is not occult and therefore that the management is different. If it's mammographically occult because the breast is really dense, you're given an M1, but it's a U5 lesion, then you want to say, look, because it's M1 and U5 and subsequently proven to be B5, that means this is an indication to do an MRI to look at the whole breast in greater detail.
Yes, right. And also the stereotactic biopsy thing is a little backwards here. So we are not so much doing stereotactic biopsy thing here. So mostly ultrasound guided core biopsy or FNACs, that sort of thing.
There are. Stereotactic biopsy is very important because I'm sure that you would have seen a lot of this locally advanced disease with a lot of microcalcifications in the breast.
True.
And then how do you then try to prove to the surgeon that actually the whole breast was involved, or even the contralateral breast, if it has microcalcification, how do you prove it? Because these are the things that you cannot see on the ultrasound that you must biopsy. So this is where the stereotactic comes in. You don't need to have fancy machine to do this. I mean, those machines that runs the vacuum assisted biopsy for the 9 gauge, the 12 gauge one, they are very expensive to buy, and the needle are very expensive, cost a few £100 per needle. Now, all you need to do is, if you have the mammogram machine, get the company to set up for stereotacticability, and all you need is this as a 14 gauge. And all you need is to go in at a 12 course around that area and capture some microcalcification, and that's enough for your pathologist and your surgeon.
Very true. Thank you so much, Tin. So maybe we'll communicate in future also regarding training and everything.
Please do. Please do.
Thanks, Dr. Chin, for your kind information, Dr. Shagupta ma'am. For this, you asked that about the after neoadjuvant chemotherapy, that lots of tumor after good chemo response, radiologically and sonologically, it is not visible. You know that for this region in UK, at their setup, Farid Ahmed SARS based unit, they use before starting chemotherapy, they use hydromark, hydrogen mark. Can you see I have on hydromark, used hydromark cell. This is a pack of hydromark. And we are using this from 2018 at our center, Anarkhan Modern Medical College. First we use this, and now it is available in Bangladesh. You can buy and use this before any neoadjuvant chemotherapy. This hydrogen mark, when surgeon and oncologist decided to do neoadjuvant chemotherapy, ultrasound guided this hydromark placed at center of the tumor under local anesthesia. It is technique. Ultrasonologists guide this, and when it is at center, you can push, just push, and the center there is a hydrogel.
Okay, that's fine.
Visible after completing of the chemotherapy for operation, when we assess that where is the marker click. Maybe complete chemo response and you cannot say anything. So after completing this neoadjuvant chemotherapy, sonologist put a wire for guiding this hydromark. It can see in ultrasound and even mammogram. If few coil is there, so on operation day, ultrasonologist under local anesthesia put a guide wire, and we do the wire guided wide local excision. And 7 wire guided wide local excision were already done after neoadjuvant chemotherapy. And wire guided wide local excision, more than 25 we done. Dr. Humayun Islam Khan actually helped us for this purpose. She got trained under Chin and others, their unit, and was for this. You can use this, and if you need any help, I can help you.
Okay, thank you so much.
Thank you, ma'am. Now I would like to invite question if anyone have, or I have to go through the chat box. Anyone can ask any question. You can unmute yourself and ask question.
I want to know one question, Ali Nafisa. I'm not very sure that, do we have any stereotactic biopsy machines in any centers in Bangladesh anywhere? Do you know? I heard Square had one. Is that correct?
We have at Square, right?
But maybe you are not doing it regularly, right?
No, we are not doing it, but we have the machine.
I know that United had a stereotactic machine, but a few days, 2 years ago, I sent down patient, they are not working actually, maybe same case.
Because nobody is that efficient. So that's that it needs a lot of training and, proper localization of the things. So nobody is doing it right now.
I mean, it all depends. A lot of it depends on how Bangladesh, you all manage your breast cancer patients. At the end of the day, do you really need to prove the second area? Because increasingly, we're all doing breast conservation surgery now, and that's the reason when all these biopsies are becoming more and more important, especially the stereotaxis ones. So if that is the trend, then you should be doing stereotactic biopsies. Very easy, really straightforward. If you can do the ultrasound one, and if you can do the mammogram, the rest is just the machine. When I do them myself, I always think I'm like a biopsy monkey, really, because I do nothing but deploy the thing. The machine does everything for me.
Yes, but after compression, everything goes this side and that side, and you can't localize the calcifications or anything.
Yes,
so that's the problem with proper localization and everything. Otherwise, it's not a tough thing, but it needs a little bit of patience and a little bit practice, I think.
Yes. Yeah, because what you can do is, if you like, sometimes if you can see a lesion, sometimes what happens is the sonographer see the lesion. On a good way to start off is to target a lesion. Say, for example, the sonographer finds a little lesion in there, say, because if you're not very confident, because it's only 1 centimeter and you're scared you will miss it. So you take the easy way out, which is actually getting the stereotaxis to do it, which is the computer targeting it for you to do it. So that's the first way to do it. Find a tiny lesion. If you think that's a cancer, don't stress yourself out doing a biopsy and the ultrasound using this. Put the patient onto the stereotactic machine, do the stereotaxis, you see the lesion nicely, and all you need to do is get the machine to target the lesion, and you do your biopsy as you would. And if you get a B5 result at the end, there you go, you've done your first patient. Start off with
Yes, I know.
Something that you don't see on ultrasound, something that you're not sure whether it's malignant or not, can be a little bit scary because you don't know whether you did it right or not when you did the biopsy for the micrococs. If you see what I mean.
May I interfere? As far as I saw in your Wycombe Hospital, stereotaxis was mainly used for very ill-defined lesions like microcalcifications, scattered calcifications.
Yes.
You've used the stereotaxis and immediately X-ray to see the sample which did have any microcalcification, then from section which showed whether it's cancer or not.
Yes, true. That's the reason.
Yes.
Yes.
This is one of the indications, and the evacuation is very good for some small solid lesions. It just takes out the whole lesion and does not require the patient to go into surgery. So, the patient sits under the machine and the device says where it is, the depth from the skin and everything. And the whole solid thing is taken out, or the microcalcification area of suspicion, bad architecture, they are, sampled very nicely by stereotactics. So it's actually one of the finest method. After when ultrasound cannot take out samples of microcalcification, which stereotactics along with mammogram can do. So we do need these machines, and of course these machines should not lie down idle like this. I hope we can work with them soon.
Yes, should be.
Yes, yeah.
Thank you. Next question from Dr. Shrikanta Banik. Yes, Dr. Shrikanta Banik, you can unmute yourself and ask this question. Are you there? Question is what megahertz probe of I don't know megahertz probe of use to see the cortical thickness of lymph node. That means that to see the cortical thickness of lymph node, which probe is used? Dr. Chin, can you?
Yes, it's the same probe that you will use for the breast.
For breast. So cortical thickness. Another question from Dr. Ayub Ali.
Yes.
What's the exact age to start a regular breast screening? What's the recent strategy?
Can you repeat? Can you repeat the question?
Ken, what's the exact age to start a regular breast screening and what's the recent strategy?
The risk for breast screening.
Yeah, age of breast screening.
Oh, what about the breast screening? You mean the radiation to the breast?
I think
I think
the question was.
I think he wanted to know the ideal is to start breast screening. I think you have already mentioned, but still he has put the question that what should be the ideal age of breast screening.
Oh, right. Okay.
And
Yes,
any newer strategy.
Okay. Yes. So the recommended breast screening here is at the age in the UK is from the age 47 to 73. In the US, they start even more earlier, and some units would recommend a targeted, a personalized breast screening. Really, it's a little bit like what the Americans would do. They stratify your risk, and then they would tell you at what age you should start screening and when you stop, and what is the interval of the breast screening. Obviously, I think a 3-yearly interval, a 2.5 to 3 yearly interval is sufficient. Any earlier than the age of 45 or 40 even, it's not very useful tool because the breast is really dense when you're younger. So the pickup is really low indeed for the ones that's below the age of 40. So I think any age of 45 and above is a good age to start screening at a 3-yearly interval. And obviously, if there is a risk factor, if you come from a family history, of a strong family history, then the protocol will be slightly different for those cohort of patients where you will start screening immediately when you know that you are a BRCA carrier, for example, with very high risk. In younger age group patient, you wouldn't do a mammogram as a screening. You would then do MRI, yearly MRI as a screening method until you hit the age of 40. Then you do a mammogram together with the MRI, depending until you hit screening age. Then you stop doing the MRI and do a 3-yearly screening from that point of view. So, I mean, in terms of age, I would go for the age of 45 and above, but the national guideline now over here in the UK is 47 and above, 3-yearly interval.
Dr. Chen.
Yeah, in a symptomatic setting, any patient who comes to you in a symptomatic setting, regardless of symptom, at the age of 40 and above, you should do a mammogram. It's just a checkup for the patient, really. The patient came, I know probably in Bangladesh, probably not a lot of ladies who come with asymptomatic breast pain. They don't get any imaging, but you should also do that. It's just part of, they come for your specialist opinion as a breast surgeon, for example, and no specialist opinion of a breast opinion is complete without a mammogram. That's why they get a mammogram at the age of 40. So it's, because it's our job, they come to get something and we give them the whole assessment.
I wanted to ask a question. You mentioned age 40, isn't it? Because previously we almost 15, 18 years we used to do from age 35, but it got changed later on. But every country does things differently. Is it to do with something with the density? Is it to do with the number of cases that you pick up on certain age? And can it vary country to country? And does it have to be cut off 40 or 47, no, this sort of things, every country?
It doesn't have to be cut off at 40. In a cut off at 35 is fine. I think breast density was the reason for the cutoff age, given a cutoff age for this mammogram. Obviously, if your unit in Bangladesh wishes to have it at 35, even better. I'm very pro for mammography, really, because I know the limitation that an ultrasound does. You see much more on the mammogram that you do not see on the ultrasound. An ultrasound is very operator dependent, very machine dependent as well. So, I mean, the mammogram is, I do like it as a complement to my ultrasound. It increases your sensitivity combined together to over 90.
Thank you very much. I wanted to ask another thing, if I'm allowed, Nafisa. Many sonologists in Bangladesh, they report on ultrasound and then they recommend FNAC. Yes. They can describe a lesion. How would you comment on that? Suppose
Yes,
if we suspect a breast cancer, do you think FNAC would be enough for a
yeah.
decision making?
Yeah, but FNAC was when I trained, we use FNAC. A few units were using core biopsy at that time, but then the trend is moving now towards core biopsy simply because, first of all, FNAC is not adequate. It's a lot of a high hit miss rate. I'm sure you guys know you do it and it's not enough or inconclusive. It's not brilliant. And secondly, the core biopsy gives you a tissue sample. You get a lot of information out of the core biopsy, the tissue receptor, the subtype of the lesion. FNAC cannot tell you. FNAC just tells you that it's malignant. They can't tell you what subtype of cancer that is. So core biopsy all the way. That's the gold standard. We all should be moving away from FNAC, really. Also, increasingly, I'm sure any pathologists in the audience would be also saying that the skill to read cytology is very fast disappearing. So more and more people are doing core biopsy now. So if you still continue to do FNAC, very few people, pathologists, would be very good at interpreting this cytology, and that leads to a danger of a misdiagnosis of FNAC, really. So core biopsy all the way. I don't mind so much the axillary lymph node for FNAC. That I'm okay with, because you don't really need to know what type of metastatic disease there is in the axilla. You only need to know whether it's involved or not. So FNAC is enough. Less stress for the patient, less stress for the sonographer. I mean, different if your breast is normal, ultrasound normal, mammogram is normal, but your axilla is abnormal, then you shouldn't do an FNAC. You should do a core biopsy of the axillary lymph node, because you need to know whether this is a breast primary and what type of breast primary it is, or is it something else like lymphoma or a metastatic disease of different sites.
Excellent. Thank you very much.
Ali Nafisa, if you allow me, then I would like to compliment Dr. Farid's comment about the sonology and sonological advocacy of FNAC. In fact, the scenario in our country is that we have some people who are purely sonologists. They are not the radiologist having the background of radiology as well as training on sonology. So that advocacy usually comes from the pure sonologists. They don't have any ABCD of the radiology. So they straight advise that FNAC is advised. But I think if a sonologist come radiologist who has got both the experience of doing interpreting mammography and as well as doing himself the sonology, then this controversy will not arise. What I think my suggestion for the pure sonologists, that when they suspect some sonologically suspicious lesion in the breast, instead of straight advocating FNAC, I think they should suggest that you should have a mammography, and then after interpreting the mammography and sonology, then the final interventional procedure like sono or mammo-guided, the TrueCut or FNAC. The basic thing is there are two groups of people. They are handling the breast imaging: pure sonologists come radiologists.
Yes, I mean, sometimes I feel that, in this subset of breast imaging, I don't see why a sonographer cannot be trained to read mammogram and to do a core biopsy as well. Sometimes I feel maybe I'm overtrained to do the job that I do, having to come through 10 years of medical training before finally embarking to do breast radiology. That can be done by sonographers. But I think I would encourage, especially in a country like Bangladesh, that
but in our Dr. Chin, in our country in Bangladesh, the vast majority of sonologists, they are not radiologists.
If they want to
majority of sonologists, they are the pure sonologists. After graduation, they train themselves, or they go for some diploma in sonology and they start the sonological practice,
Yes.
but they don't have any basic idea about the radiology. That's
Yeah.
why the discrepancy.
Oh,
That's the problem.
yeah. I think especially in breast, it would be good if the sonographer specializes in breast itself, because breast is quite different from different areas of sonography. Obviously, I know Dr. Humaira Islam is very, very good at doing general imaging in ultrasound as well as breast. But to take it one step further, doing the core biopsy and also reading the mammogram together with it would complete the sonographer as an advanced practitioner. In my unit, I have a sonographer who was actually a mammographer turned into a clinician that worked alongside me, just as good as me. And I always ask her opinion if I'm in doubt. So no reason why your sonographer cannot specialize in this field. It's a very big field. A lot of women get breast cancer. It's a very important field, I find.
Thank you, Dr.
Thank you.
Can I add? Yeah.
Okay.
Nafisa, it's of course what in order to value Dr. Khadimul Islam's opinion, yes, it is very, very valuable that it should be a combined reporting. But most of the time, many centers still do not have mammographic units, and there's only sonology. And as far as I'm doing here in my chamber, I always ask the patient if they have mammography done.
Yes.
And it is, we see many patients are not even also recommended for mammography, and they are just asked to do ultrasound. So there are, opinion variations, and it's not always easy to do patient mammogram and ultrasonogram without the patient who referring doctor asking us to do mammogram and ultrasound, because in our center we do have mammogram and ultrasound. So a patient can be referred here to do a mammogram first and then ultrasound. But in many cases, we do find that the patient are referred only for ultrasound, and they are not advised mammogram at all.
Yes, mammogram.
So this should be, widely known that a patient should have both the things together before core biopsy or any kind of biopsy is done to the patient.
Yes,
and I am reading mammograms in most of the patients wherever I can put my hands on if it is done, and I do advise mammography for comparison studies also. Yeah.
I mean, it is not unreasonable to start and have a mammogram above the age of 35 and above. I think it's a good number. If one of the audience asked me what is a good age, 35 and above is a good age in a symptomatic setting, of course. And patient above the age of 35 comes to a clinic, gets a mammogram. It should be the other way around, actually, Dr. Humaira Khan, because, if my mammogram is normal, I do not want to ultrasound them, especially if the surgeon thinks that the breast is normal. Say, for example, the patient has a little, maybe itch around the nipple, for example, or little skin tag on the nipple. I don't need to ultrasound that, but what I need to do and what you need to do as the surgeon is to make sure that there is no breast cancer in the breast, that the patient isn't aware of, or any other findings not associated with that. So we do a mammogram. If it's normal, surgeon's happy that the abnormality is not breast, maybe skin changes related or on the nipple, then we don't need to do an ultrasound, because you all know that the ultrasound will give you a lot of false reassurance, and we don't like to reassure the patient like that, because the patient may go away in a few years' time, develop cancer, and if you look back, she didn't get a mammogram. How am I to know that you didn't miss something in the breast that was very subtle that you would not call on ultrasound normally, but was there on mammogram before? So yes, mammogram is first. If I have to choose between two of the imaging modality, which one would I go for if I can only have one test? The one test will be mammogram first.
Is that gold standard?
Absolutely correct.
I want to share.
Hello. Uh,
I want
you,
to share a
Dr.
case.
Chen.
Recently, one
Nafisa.
of my
Yeah.
sir, recently
sir.
one of my niece in Nalipras married 44 years lady
Yes,
came to
yes,
me with a palpable subareolar lump in her left breast.
yes,
Mammogram shows normal findings.
yes,
Ultrasonogram shows a well circumscribed mobile
yes,
breast lump about 3 into 2 centimeter. And there is some visible lymph nodes in left axilla.
okay,
Sonologist ensure her not to worry because it is virus 3. You can wait the corona after corona situation. You can do the further investigation. I advise her to do core biopsy
yes,
because she is a patient of a cancer family. Her
yes,
twin sister died on bilateral ovarian cancer.
yes,
Her mother died on uterine cancer, and
yes,
her father died on cholangiocarcinoma.
that's right.
And she is the only person in the earth living. I advise her to do core biopsy. Core
Yes,
biopsy reveals
grade 3.
high-grade infiltrative duct cell carcinoma,
Yes,
ER, PR, and HR2 all are negative.
yes, triple negative cancer. Yeah.
This is the scenario of
Yes,
the imaging.
yes. Yeah, but that's the thing.
The scenario in my country.
Yes, we always see that. We see that very often because high-grade DCIS on the ultrasound can be really difficult to delineate. If it's a P1, if it's a P1, then it's nothing. But if the surgeon says, "Yep, it's it feels very abnormal," then any subtle changes in the breast, you should raise the suspicion of a biopsy. But not uncommonly to your story, Prof, that you can have an M1U1 but a P5, and in which case then the surgeon should do a clinical core biopsy of that area to completely exclude, because there are changes in the ultrasound that is not like a lump. It can be quite diffuse that the whole breast is involved. You wouldn't be able to tell. But a low threshold for core biopsy should always be the key to this. It's not a difficult thing to do. It's a local anesthetic, and it gives you the answer straight away.
Thank
And
you.
especially in ladies above the age of 40, you should be getting new fibroadenomas growing, new lump growing. I mean, any new lump in that age group should be, you should have a level of concern. And also a grade 3 tumor, as I've spoken in my slides earlier. I wish I could show you more grade 3 tumors, or even a lot of them look really benign, look like cyst even, but it's actually solid, or this aggressive cancer, they look like fibroadenomas. So you would technically call it as a fibroadenoma and not biopsy them. And that's quite a worrying trend. So I think the age, if it's 20 years old, then you might say, yeah, it's a fibroadenoma, you can leave it alone. But at the age of 40 and above, low threshold for biopsy.
Just wanted to compliment 30 seconds of this, if you allow me. Professor Nishat Begum gave a very good case scenario. This patient should ideally, because it's a triple negative cancer, should ideally be treated with a neoadjuvant chemo first. And before starting neoadjuvant chemo, she should have a marker clip.
Yeah.
Has she got a marker clip put in?
Yes, yes.
Excellent. And she would definitely need a genetic test, because this is the time you're buying while she's getting neoadjuvant chemo. She can complete her genetic testing. And if genetic test found, it's highly likely that she would be BRCA1, BRCA2, or TP53 mutation positive. In that, surgical treatment after neoadjuvant chemo could be entirely different. She well may need a bilateral mastectomy and reconstruction. So I'm just giving a general information, but this is a very interesting case you mentioned. Thank you.
Thank you. Thank you.
Thank you. We have two questions, although they're short of time, but I would like to read the question.
Yes.
The surgical oncology, I don't know who is surgical oncology, asks a question. As Dr. Nafisa said, hydromarker use hydrogen or it hydrate with fluid and remains visible after chemo. Here I want to ask that remain visible after chemo or not.
Yes, okay. Hydromark is visible after chemotherapy, yes, but sometimes they can degenerate and not be seen so much on the ultrasound. And if you, for example, put in the hydromark, say maybe the patient came back 6 months later and you find yourself struggling to find the hydromark, which can happen, then you would localize it using the stereotactic method.
And we have a metallic clip in this in the hydromark gel.
Yes.
Coil.
That is not hydrogen. That is metallic clip.
Yeah, so it's a metallic clip, and what
it's
it does
not hydrogen. It is called hydromark because it absorbs water around it.
That's right.
And we see the clip in the center of the fluid absorbed.
Yeah.
So it is a titanium clip which does not have any side effects.
That's right. So it's got a gel, a gel layer inside the around the clip. Yeah. So once you put it in, it creates a little gel, like a gel foam around that clip. Sometimes that gel foam dissipates. And those of you doing ultrasound would know sometimes the clip is meant to be really bright at you, but sometimes the lady's breast is very bright. So bright on bright, you can't see it. It's only if the breast is dark and the clip is bright that you can see it. I have encountered a few times where I struggle to find the clip on the ultrasound, even though I know I should find it. And in which case, I just don't waste my time, put it onto the X-ray machine, get the X-ray.
Yeah.
Thank you, Dr.
And also, I mean, on this point, yes, on the stereotaxis, how do you practice your stereotaxis? Inserting your wire under stereotaxis is also a good way to start practicing. I know you can see it under ultrasound, but try doing it under the X-ray machine. You can see the clip, you target the clip, put the wire in, and you check to make sure that your wire is the right place. So there you go, you've done your first stereotaxis.
Yeah.
Thank you, Dr. Chen. Another question asked by Dr. Hassan Mahmood. He asked when we should start radiological evaluation of operated breast after breast conserving surgery after completing radiotherapy. When will start radiological evaluation after radiotherapy or breast conserving?
I think Farid can answer that question very well for you. Actually, I think it's the recommendation is 1 year after your treatment. Over here is 1 year from the date of diagnosis. But obviously, sometimes, with all the chemo and everything in between, patient going away, looking for second opinion, it'll be 1 year before the patient had the surgery. So really is no point from the 1 year. So ideally 1 year post-surgery is what I would tend to recommend if, if the surgery and the diagnosis date is pretty close, a few months in between. So if you start 1 year from the anniversary for the next 5 years is the follow-up. Some people follow up for 10 years. Mammographic follow-up, not ultrasound, in this case, post-treatment changes in the breast, ultrasound is not really helpful. I mean, it's just all very difficult to interpret on the ultrasound. So don't bother with the ultrasound. Do your mammographic follow-up for 5 to 10 years, unit dependent.
It also depends. Thank you, Chin, for answering it. Very clearly mentioned. But it also depends on age of the patient. If patient is, she is 35 or 30 years of age and patient had breast cancer, she need to be followed up annual mammographic surveillance, surgery up till age 50, and then she can have a screening mammogram 3 yearly basis until age 74 or more. Do you not agree?
Yes, that's right. That's right. Yeah. I mean, different unit in terms of this follow-up, different units run differently. I'm sure in Bangladesh different. I've worked only with Farid for the past 1.5 years, and it's really different. My old unit runs at 5 years only and full stop. And again, like you, any patient who's younger, 30, obviously mammogram is not the way to follow up. You might consider MRI follow-up that way.
Yeah, the problem is you don't have the funding for the MRI in UK. We haven't had the funding for MRI, MRI and mammo surveillance.
Yeah.
So if we had the money, I would definitely agree with you that MRI would be the best one for younger patients.
That's right. Absolutely. 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 I mean, in Bangladesh, maybe it's a private sector, so you can then tailor your how you want to follow up your patient according to that. I mean, obviously, in the NHS, we have to, be doing things according to the funding and what we are capable of. But in the private sector, then you might think differently. So in the private sector, you might say any breast cancer diagnosis with a dense breast would automatically qualify for an MRI. It's not, isn't it? It's not a, oh, you can't do that type of thing. I mean, it's indicated because your breast is dense. To get an MRI, it's a
see you soon in Bangladesh, Chin. I wish to see you soon in Bangladesh.
Oh yes, yeah. Then we can do a training of the core biopsy, isn't it? And the stereotactic, hopefully.
In the future, I'll be chasing you a lot for tomosynthesis and stereotaxis.
Yes,
so
that's right.
Be ready for that.
Yes, the sonographers should be picking up. If you are doing breast work, sonography, and giving the setting in Bangladesh, you then should pick up the mammography as well. And of course, with the, I'm sure you have a radiologist, trained radiologist that can lead to guide.
Nafisa,
yes,
can you hear me?
Yes.
Asur prayer time is just passing away. So thanking everybody and thanking you. I just want to leave the session.
Okay. Thank you, sir, for joining with us. Actually, we also want to wrap up this program. I would like to say thanks to all of this foreign faculty, national faculty, and participant and international participant for joining with us and enlightened our knowledge. I hope in future Bangladesh will progress more and more at the level, hopeful. And actually, Khadimul Islam sir, last of all, I want to say that Khadimul Islam sir is my teacher, and he introduced me with Dr. Farid Ahmed sir. And after this, I got a chance to train in your center, Dr. Chin, 4 times. And lots of time I disturb you for sonological technique. And you also support us to give the chance our radiologists to train under your supervision. And actually, Khadimul Islam sir initiate everything, and we are doing that more and more. And I think in future, Khadim sir also support us and actually Dr. Farid Ahmed sir, you know that Dr. Farid Ahmed doing lots for Bangladeshi people and doctor and patient to establish the modern management of breast cancer like UK, and you know that we have no protocol and guideline on our own. So we the ABS and NICE guideline, and as a Bangladeshi.
Yeah, I mean, one of the guidelines that is very important, because breast imaging is, a lot of it is radiology as well. I mean, a NICE guideline, not so much actually, but ABS, yes, for the surgical management of things. But I definitely recommend you, I've got lots of writing in here, but this is what you really need to read. It's the guidance on screening and symptomatic breast imaging. Is 4th edition, is the Royal College of Radiology.
I will send that link. I'll send that link to everybody. No, thank you. We'll get that link sent it.
Thank you everyone to joining with us, Dr. Shubindu sir, Dr. Humaira Islam, Dr. Farid Ahmed, Ayub Ali sir. Thank you everyone, Dr. Chin. Thanks a lot.
You're welcome. Yeah, thank you.
Then it was very nice to see you, and